我想我们就开始这个 session 的这个演讲。那I'm Wayne Chen from Taipei Veterans General Hospital. It gives me a great pleasure to introduce our next speaker, Professor Dr Hussain. He currently is a chair and professor and consultant in the medical oncology Institute of Translational and Strategic Medicine, Prismans University, and in the Peninsular School of Medicine and Dentistry in UK. He got his MD degree in 1994 at the University of Karachi, Pakistan. And then he moved to UK since 1998 and finished his MS degree and MD degree in University of Birmingham. His major interest is in the bladder cancer, and what makes him very important for us right now for the IO era is that he is the NICE expert panel member, and for the appraisal of tislelizumab reimbursement in MUC. So we would like to hear his lecture and sharing his experience on treatment of metastatic UC. So let's welcome Professor Hussain.
Great. Thank you very much, Dr. Chang. Thank you, Dr. Cha. It's been a pleasure to be in Taiwan. I'm really excited to be here, and I came here last night and have had really wonderful meetings with a number of colleagues yesterday as well as today. So what I will do is that I will set the stage in terms of the changing landscape in the management of advanced bladder cancer with significant new drugs and treatments that are coming through. Just to give a background, over 35 years, there was very little that changed in advanced metastatic bladder cancer, but in the last 5 to 10 years, there's been significant improvements, and there have been new drugs that have literally transformed the outcomes in bladder cancer. And one thing which I'm really excited about is that we have moved from first line and second line to even third line clinical trial and chemotherapy treatments in advanced metastatic bladder cancer. And we'll go through the slides with you. So this was the stage previously, which is platinum eligible patients. The median survival was around 14 to 15 months. And in cisplatin ineligible patients, the median survival was around 8 and 9 months. And this is based on large randomized trial and more up-to-date data as well. So this is how the state was till it all changed in the last 5 to 10 years. This was the Maria DeSantis work and Joachim Belmont, and again, as I said, 9 months and 8 months in cisplatin ineligible patient group, and patients with both renal dysfunction and poor performance status, that is performance status 2, their outcome was much worse in that group of patients. Some work we did in Birmingham a while ago, looking at splitting the dose of cisplatin, which they're using the 70 mg per meter squared, but splitting it into day 1 and day 8, 35 mg per meter squared with gemcitabine, a small phase 2 study that showed some encouraging results as well. But since the advent of immune checkpoint inhibitors, there's been some really exciting developments, and I would like to go through some of those work that lots of the colleagues around here and many of us have been involved in changing that standard of care. So with the immunotherapy, there's a significant role of immunotherapy in different pathways, and again, Professor Tanner and Axel had talked a lot about some of these immune checkpoint inhibitors in kidney cancers as well, which has significantly changed the outcomes in advanced metastatic kidney cancer as well. So moving on to the first line, PD-1, PD-L1 inhibitors, for example, we see atezolizumab versus platinum ineligible patients. You see a good response rate, objective response rate with pembrolizumab as well, and a median survival which was 15.9 months with atezolizumab in first line cisplatin ineligible patient group. And that is quite an exciting figure because we've moved from 8 to 9 months. And that's when we go to the NICE committees and other panels, it is an unmet need. Cisplatin ineligible patient groups with a median survival of 8 to 9 months with chemotherapy, and with very little in terms of toxicity-wise. It is much better tolerated than chemotherapy, although there are some other toxicities, some immune-mediated toxicities that as a larger oncology and urology community, we have to be very carefully monitoring and looking after those patients and those side effects. But at the same time, it's almost doubling of the median survival in this atezolizumab study. And with pembrolizumab as well, there was a good response rate and good outcome data as well. And we'll go through some of the updated data on those. So with PD-L1 atezolizumab, it inhibits binding of PD-L1 to PD-1 and B7.1. And that is how it enhances the T cell priming and reinvigorates the suppressed immune cells. By leaving the PD-L2, PD-1 interaction intact, it does preserve the hemostasis as well, and that also helps in a positive way in terms of the benefits, and at the same time having a good sort of a toxicity profile. So in terms of this study, cohort 1, cisplatin ineligible patient group, atezolizumab 1200 milligrams was given, very standard cohort, so no prior systemic treatment, EPOC PS 0 to 2, and cisplatin ineligibility was based on these factors, which are defined more recently by Matt Galiski and other colleagues, a JCO paper that has helped to streamline the understanding in terms of the cisplatin ineligibility patient group as well. And that was what was interesting, that both in IC2 and 3, that is PDL positive, as well as those who had less PDL positivity, there was ongoing response rates that we were seeing, and there was including some CRs that you were seeing as well. So there were some cases that, as was shown by my colleague previously, that we do see some patients who are prolonged sort of responses we are seeing with ongoing sort of where we can start using the term that whether we are curing a small subset of patients with these advanced cancers. And again, change in tumor burden was significant. You can see with the advent of the use of the drug, there was significant reduction in the tumor burden, and the durability of response as well was very striking in these cases. In terms of the overall survival, if you look at the full group, the median overall survival in terms of overall 15.9 months, and as a paradoxical for PDL negative patients it was 19 months and PDL positive 12.3 months, but with a median survival overall of 15.9 months. And again, PDL1 is a biomarker that is not the remit of the talk, but it is a dynamic biomarker, and there are a lot of confounding and conflicting and contradictory things that we're seeing with PDL1, and that perhaps is something that we will hopefully discuss at some point later as well. So overall survival was significant. Toxicity was very well managed, and again, that was quite interesting, and it's good to see that actually in terms of grade 3-4 toxicities, it was well tolerated. 8% had AEs leading to treatment withdrawal, but there were no major differences in AEs across the PDL1 subgroups, and most of the AEs were generally sort of well tolerated, and more of them were grade 1 and 2, and very few grade 3 and 4. So when we usually see, as you will see, the randomized trials that we have done combined, sort of comparing it with chemotherapy, there's significant sort of toxicity profile favors the use of immune checkpoint inhibitors in those settings, knowing that sort of advanced bladder cancer had always been given a Cinderella status, and there's been little research and little moves that has moved forward. I think these are sort of studies that have really excited the things in terms of improving survival at the cost of minimal toxicity. And again, immune-mediated toxicities are key, and again, as we were talking previously as well, it is important that we focus on those toxicities to try and basically treat them early, identify them early and treat them early. That's going to be the key messages that will come across when we are looking at immune checkpoint inhibitors, because you can easily lose patients if we delay intervention in some of these cases. So again, in terms of the grade 3-4 toxicities, very minimal grade 3-4 toxicities we are seeing. Rash AST increased, but otherwise generally very well tolerated. And the toxicity risk grade 3-4, we're looking at 1 to 2%, which is quite significantly low. This was the 052 study with pembrolizumab, which was a multi-center single-arm phase 2 trial. Very similar design, looking at single arm, basically pembrolizumab in patients who are ineligible for cisplatin. And again, PD-L1 assessment was done using a combined positive score, looking at that to try and see that basically PD-L1 expression, can it predict the outcome as well. So it was stratified on that basis as well. And 541 patients were screened, median age 74 years, 11 patients were above 85 years. So we do see that actually these are the drugs that can be used in patients with elderly patient population groups as well. And the median survival was 11.5 months. Again, I would say very interesting median survival, considering that with chemotherapy we see 8 to 9 months of median survival. In terms of the toxicities, we saw very similar toxicities to what we have seen with atezolizumab, and again, fatigue, pruritus, rash was seen, but in a small percentage of patients, and especially when you look at the grade 3-4 toxicities, there were very small numbers of grade 3-4 toxicities for patients who were cisplatin ineligible and treated with pembrolizumab as well. So with 11.5 months follow-up data, the median survival of 11.5 months in cisplatin ineligible patient group with pembrolizumab was quite interesting as well. So I think in terms of both atezolizumab and pembrolizumab, these drugs are available for patients in UK, basically for cisplatin ineligible patient groups as well, based on that data. In terms of the platinum refractory setting that we'll come to, and again, we talked about that the median survival in platinum refractory setting, second line setting, was about 6 to 7 months. The trial that was only phase 3 trial prior to this work was Joachim Bellman's work, which was published in JCO, and that was looking at a median survival of 6.9 months for vinflunine versus 4.3 months for best supportive care. So again, what has changed in the last 5 to 10 years has been an advent of these significant amount of drugs, atezolizumab, nivolumab, pembrolizumab, avelumab, durvalumab, which has gone through different clinical trials. I will focus through